Welcome everyone. So if you're gearing up for high-stakes nursing exams like the NORCET, I know perfectly well that acid-base imbalances can feel like this intimidating, confusing medical mystery. Seriously, it trips up so many people. But today, we're going to change that completely. In this explainer, we're going to break down this complex physiological concept so clearly and so systematically that it's going to entirely remove your fear of the topic. By the time we wrap up, you'll be guaranteed to secure those absolutely crucial exam marks.
All right, here's our roadmap for the day. We're going to cover mastering acid-base imbalance, the golden ABG numbers, decoding compensation levels, safe ABG sampling practices, and finally, we'll test it all with some real-world clinical scenarios. Let's jump right in.
Starting off with Section 1, Mastering Acid-Base Imbalance.
Okay, I want you to adopt a real battle cry mindset for your exams today. No backing down. Understanding your patient's baseline numbers is the absolute key to solving literally any physiological mystery that the exam, or honestly a real-life emergency room, can throw at you. So here is the ultimate rule you absolutely must memorize. As your pH level rises, your bicarbonate rises too. They move together directly. But, and this is a big but, as your pH rises, your carbon dioxide drops. It's a strict inverse relationship. Drill this into your brain right now, because every single thing we talk about next builds on this foundation.
Moving right along to Section 2, the golden ABG numbers.
Now, before we look at the optimal state, I need to give you a stark warning. If a patient's pH drops below 6.8 or spikes above 7.8, well, it essentially means game over, imminent death. Your window to keep a patient alive here is incredibly narrow. The normal optimal pH range of human blood is strictly 7.35 to 7.45. Any dip below 7.35 means your patient is slipping into acidosis, and any rise above 7.45 triggers alkalosis.
Next up is carbon dioxide, or PCO2. The normal range here is 35 to 45. So the crucial point is, you have to memorize this carbon dioxide level, mainly because CO2 actually acts as an acid in your body. It's wild, right? As your respiratory CO2 rises, your blood pH dangerously drops. Think of them as being on a biological seesaw.
Our third golden number is bicarbonate, or HCO3. The normal range for this one is 22 to 28. And listen up, because here is an absolute examiner favorite detail to tuck away for test day. Bicarbonate naturally outnumbers carbonic acid in the human bloodstream by a strict 20-to-1 ratio. Seriously, do not forget that 20-to-1 ratio.
And this brilliantly illustrates the chemical behavior behind these states. You see, acidosis means the body has this massive excess of hydrogen ions that it just wants to donate. And chemically speaking, acids have a sour taste. Alkalosis, on the flip side, is a base-heavy state that is just desperate to receive hydrogen ions to find some sort of balance. And bases, they naturally have a bitter taste.
Real quick, before we move on, let's anchor a handy memory trick for your electrolytes, because man, this trips up so many students. For intracellular fluid, or ICF, just think of putting ice in a drink. Your ICF contains the P elements, potassium and phosphorus. Meanwhile, your extra elements, like sodium and chloride, they live strictly outside the cell in the extracellular fluid, or ECF.
All right, let's tackle Section 3, decoding compensation levels.
Okay, I will completely acknowledge that compensation is famously the trickiest part of the exam, for sure. But we're going to completely simplify how to tell if the body is successfully fixing its own chemistry. Let's look at this table. See the top row? A normal pH instantly proves the body is fully compensated. It fought the imbalance and hey, it won. But if your pH is abnormal and your secondary value, like CO2 or bicarb, is also abnormal, that means the body is actively trying to fight back. We call that partially compensated. And if the pH is abnormal, but the secondary values are just sitting there perfectly normal, that's uncompensated. The body hasn't even started fighting yet.
Moving to Section 4, Safe AGB Sampling Practices.
So, to actually get all these beautiful numbers we just talked about, we have to draw arterial blood. In a clinical setting, your absolute first priority is the radial artery right there in the wrist. If that fails, you go for the brachial, and only as a last resort, you go for the femoral. But listen carefully. Before you ever touch that radial artery, you must perform the Allen test. This is a mandatory clinical assessment of the ulnar artery's patency. Why? Because if you puncture and accidentally damage the radial artery during your draw, the ulnar artery is literally the only backup blood supply left. Without checking it first, you risk the patient's hand actually dying of oxygen starvation. No joke.
So here are the exact examiner favorite steps for the Allen test. You compress both the radial and ulnar arteries while the patient clenches their fist to push the blood out. Then you release only the ulnar side. And I really want to stress this triple-star exam detail. You must watch the patient's pale hand, and a normal, healthy pink color must return within exactly 6 to 7 seconds. If it does, boom, you're clear to draw from the radial.
And when you do finally draw that blood, you need very specific equipment. You must use a heparinized syringe. This prevents the arterial blood from immediately clotting in the tube. Oh, and you only require exactly a 1 milliliter blood sample. It's a tiny, tiny amount, but it holds all the answers.
Finally, Section 5, Real-World Clinical Scenarios. Let's see how this all comes together. All right, it's time for a rapid-fire clinical gauntlet. We're going to instantly test your newly acquired diagnostic framework with the exact kind of high-yield questions you will absolutely see on test day. Ready? Here's Scenario 1. A diabetic patient arrives at your emergency department. They have a total lack of insulin, which has forced their body into severe fat breakdown. So what specific acid-base imbalance is occurring during this diabetic ketoacidosis, or DKA?
The answer is metabolic acidosis. Because the body is breaking down fat for fuel, it rapidly accumulates these acidic ketone bodies. And you'll physically notice this when the patient exhibits deep, labored Kussmaul respirations. They are literally trying to blow off the acid through their lungs, and they'll have that classic, distinct, fruity breath odor.
Let's look at Scenario 2. You've got a patient who is rapidly losing massive amounts of their stomach contents, maybe due to severe vomiting or maybe continuous nasogastric or NG tube suction. What chemical imbalance does this trigger? Think about it.
Now, what is truly fascinating here is just the basic math of the human body. By forcefully removing massive amounts of hydrochloric acid right out of the stomach, you mathematically force the body's overall base level to spike. Less acid equals more relative base. Therefore, the result is metabolic alkalosis.
Okay, here is our final tricky medical mystery. You are assessing a patient with acute pancreatitis. How exactly does this inflamed pancreas link to a very sudden, very dangerous electrolyte shift in the blood?
Here's what happens. Acute pancreatitis causes a massive spike in phosphorus levels. And because of the fierce, sworn biological enmity between calcium and phosphorus, this phosphorus spike causes an immediate drop in calcium. This results in dangerous hypocalcemia. It's like they're fighting for space. They simply cannot coexist at high levels.
Please, cement this golden rule of antagonistic electrolytes into your mind right now. When sodium rises, potassium falls. When calcium rises, phosphorus falls. They are biological enemies. Knowing this single concept will absolutely save you from second-guessing yourself on countless exam questions.
Wow, we have covered immense ground today, and you now hold the master keys to decoding literally any acid-based imbalance. You are completely ready to crush these NORCET questions. But, it leaves you wondering, if the human body fights this hard, with this much incredible mathematical precision, just to balance a single acid, what other brilliant, hidden chemical wars are happening inside your patients right now? Trust your preparation, apply these rules, and keep fighting for your goals. Thanks so much for learning with me today.